Hello again, this is Paul Barach coming to you from Hospital Management Asia 2015. This is the Patient Safety Certificate Program pre-conference. This is a series of podcasts that you'll be hearing as part of your program. Today we'll be speaking about recognizing the importance of collaboration and effective communication for safe and high-quality care. Why study and improve patient handovers? We know that clinical handovers are often suboptimal due to over or incomplete and seriously misunderstood information or delayed or absent information exchange. We know that there's a high number of adverse events, perhaps as much as 10 to 25% of handovers have adverse events. We know they're highly related to medication errors and diagnostic follow-up errors. We know most of them are preventable, and we know they cause a huge amount of extra cost, perhaps as much as $1.5 billion in the Netherlands, perhaps as much as $85 billion in the US, perhaps as much as $25 billion in Australia. The Joint Commission, in its annual review of adverse events and root cause analysis, shows in this slide that failures in communication are the single most common root cause of sentinel events reported every year. For example, in this slide, from 1995 to 2004, as you can see, of 2,966 events, about 65% were related to communication as the sole root cause of sentinel events. In this cartoon, you can see this relationship between ducks and giraffes, and of course, here the giraffe says, unfortunately, animals lack the skills to communicate with each other. The chicken says duck, and the giraffe says where. And of course, this highlights the miscommunication and misunderstanding between providers, albeit speaking in the same language, but misunderstanding each other. This slide from the New England Journal of Medicine from Harlem Krumholtz's group from Yale shows us that the proportion of rehospitalizations of patients for causes other than the condition at initial discharge. So, for example, you can see that amongst patients in heart failure who gets readmitted to the hospital, 63% of patients were readmitted not because of heart failure, but because of associated failures in other comorbidities. This was equally true for pneumonia, COPD, and gastrointestinal problems. The Joint Commission and the World Health Organization have both been calling for a focus on improving handoffs and better communication both inside the hospital and between the hospital and the community. The Joint Commission's National Patient Safety Goals list handoffs as one of the top 3 issues. Equally, the Australian Commission on Safety and Quality, in addition to that, the European Working Group on Safety and Quality in Healthcare have all called for handoffs to be a number 1 priority in healthcare research and services understanding. The Institute of Medicine in the U.S. has also called for this, particularly focusing on the need for teaching programs. That is to say, residency programs, fellowship programs should train residents in how to hand over their patients using more effective communications. When we talk about handoffs, we talk about the taxonomy of handoffs, either extra-hospital or outside the hospital, for example, discharge to home or to rehabilitation from the emergency department or from a patient ward, or admission to the hospital, either from the EMS or from the emergency department or from a separate floor. And finally, department transfers in the hospital. A separate and related category are intra-hospital handoffs. Those are the ones, obviously, between escalated services, for example, in and out of the intensive care unit, for example, between med surgery or the OR and the PACU, or, for example, shift changes, for example, in the intensive care unit between the afternoon and the night shifts. We know very clearly that shift changes represent transitions that can impact the quality of patient care. The literature suggests that perhaps as much as 80% of transitions of care are fraught with process failures, and many of them lead to adverse events. There's wide variation across institutions, across professional roles, across shifts, and across individuals. We look at handoffs as part of the clinical microsystem. And in this slide is an example from a recent study that we did in which the interns and the nurses have very different perspectives on the transition of care. Here's the intern saying, no big deal, just part of the work that has to get done. The nurse, however, is saying, we are the constant presence at the bedside and the transitions ignore our care at times. Because of the nature of the work, the limited time spent on each service, and the local variation, the next slide highlights what most trainees think, which is they just show up for service. They don't actually get trained in a formal way for transitions of care. The result of this lack of focus is that they quickly adopt whatever form of handover practice is accepted on that service, irrespective of its safety or effectiveness. This is a perfect example of the operation of the informal or hidden curriculum, which is rampant in medicine and nursing. In 2010, the ACGME, which is the agency responsible for trainees in North America, and then the European work hours in 2012 both called for a restriction of duty work hours and a focus on handoff education. These requirements mean an explicit core competencies that are part of what every intern and resident must be able to accomplish before they can matriculate to the next level of training. Soleil and others have shown that there's a lack of national standards for patient handoffs. In this study in the mid-2000s, only 8% of medical schools actually taught how to hand off patients in a formal didactic session. The vast majority of medical students are taught by interns or residents who were likely taught by their own interns and were never formally trained. In this schematic, Matt Weinger and myself back in 2007 published a framework for better understanding the situational awareness, or what are people thinking about as they're trying to do work together. In this case, the interplay between the task that needs to be done, the environment in which the task is happening, and what's happening in the heads of the providers leads to misunderstandings and flawed mental models. Ken Catchpole, in this elegant study back in 2008 and 2009, showed that the number of errors, the information omissions, and the duration of handovers are all related to the standardization or lack thereof of transitions of patients. For example, in an intensive care unit done in the UK, Catchpole showed that before and after errors and information omissions went down when protocols were introduced into the care and the transition of patient from the operating theater to the clinical ICU. In addition to that, the duration of time went from, on average, about 11 minutes down to 9 minutes when a transition of care was introduced using handover protocols. The next slide shows very clearly how the number of errors reduced and the performance improved after the introduction of a standardized protocol. We and others have done a lot of work on understanding the team competencies that are required. These could be either team generic or team specific, and what we mean by that is a team generic task might be transporting the patient from place to place. A team specific might be when team membership is stable, how do we actually manage the team at hand? Now, clearly, the different types of teams might also mean that we have to approach them differently when we like them to change their behavior. This slide reviews our work on TeamSTEPPS. This was a project that was designed by multiple people, including Ed Salas, Heidi King, Jim Battles, Dave Baker, and myself, Paul Barach. We published this in 2006. This framework speaks to the interplay between the trust, the shared mental model, and the communication between team players. At the heart of these frameworks are 5 separate core trainable elements. Number 1, team leadership. Number 2, team orientation. Number 3, the adaptability of team members. Number 4, the backup behavior between team members. And finally, the mutual performance monitoring of each team member of their colleagues. Clearly, the relationship between these core elements can come into play into specific competencies, that is to say, knowledge, skills, and attitudes that we can train for, select for, and of course, supervise. Here's an example of the quality of patient handover in intensive care units in England. In this study that was done over the telephone, what they realized that systems that had handover protocols in place had much better understanding and input from a variety of team members. That is to say, when in fact there was a structured handover, less adverse events occurred. Harold Lossell has showed us that understanding handoffs as a form of communication is more than just the words, but actually the coding and encoding of the words and sounds in order to get a better understanding in the listener. What this means, according to Harold, is that who says what to whom, in what channel, and with what effect can have a huge influence on the overall outcome of this transition of information. Alistair Cockburn has shown that the richness of the communication channel is directly related to the type of channel. For example, if you communicate via paper, via audio tape, or via email, these are highly poor forms of communication. They're not particularly effective versus a phone conversation, a face-to-face, or even better, a face-to-face at the whiteboard when you're actually pointing and gesturing and making it very clear what the information is and confirming that the information is understood by the listener. We know from Kazar's work that there is a broad understanding of the psychology of miscommunication. Speakers systematically overestimate how well their messages are understood, especially men, especially young men, whereas an egocentric heuristic might mean that senders assume that the receiver has all the knowledge that they do, and therefore they understand exactly what's being communicated. On the other hand, the listener is in a place of hoping to better understand what's being said, cannot necessarily control the speed, the timing, or in fact the efficiency of the communication sent to them. In this study done by Barfunger, Saltler, and Long, what they showed was that readbacks were key in reducing errors in lab reporting. In their study, they showed that as much as 29% of lab reports were erroneous because of a lack of effective readbacks. This is quite common, for example, at McDonald's or Burger King, in which readbacks are a central part of every type of order, and therefore they're able to get to about a 98% of accuracy versus a common average in hospitals, which is about 29%. Ashberg and Quira showed in 2004 that communication done by technology alone is not enough. In fact, what we need is a phone call superimposed on the electronic communication to ensure that urgent labs don't get missed. Another example of these problems in technology is when trainees cut and paste without understanding what actually happened, and by doing that, they repeat, copy, and paste text that might be erroneous and might lead to misunderstanding. Emily Patterson, Roth, and David Woods have shown that in other industries, for example, nuclear power or aviation, there are clear standardized strategies and updating information modalities that allow providers during the transition of information to go to limited distraction and overall more effectiveness. This includes standardizing templates, updating information, limiting interruptions, face-to-face verbal updates with interactive questioning, and finally, clear and structured readback to ensure the accuracy of the information. In the next slide, I want to review a variety of studies. The first one is Project Achieve, led by Mark Williams, funded by PCORI. And what this study is about is understanding hospital and community context and how the clinical care is highly connected to the social wellness and welfare of the patients. And it's only by coupling the health and welfare and looking at the organizational culture, the change climate, and the resources can you actually have integrated healthcare systems that reduce adverse care. In the next slide, I want to talk about the Project Handover. Project Handover was a study that was done by multiple researchers from around Europe. And what this study shows in this slide and the next slide is that we tried to look at handoffs as a process. That is to say, replicating Deming's original aphorism saying that the first step in understanding a process is to draw a flow diagram. Then everybody understands what his job is. If people do not see the process, they cannot improve it. I want to review briefly process mapping. Process mapping is a fundamental skill that every industrial engineer does in their first day in training. And what it is it allows us with simple ovals, boxes, diamonds, and arrows to highlight the complex interaction. In this paper, published by Vinny Arora and Julie Johnson many years ago, in building a standardized protocol, they looked at what are the key core elements in modeling a standardized protocol, the process, the content, the implementation, and most importantly, the monitoring. In this next slide, work published by Vinny Arora, Julie Johnson, and myself in 2007, we looked at modeling the behavior and the transitions of care for the anesthesia resident for the patient moving from the OR to the ICU to the ward. As you can see from this diagram, very clear delineation of responsibility separate than the backup behavior. These two functions are clearly at the heart of many inadequate and failed transitions of care. We've learned from process mapping that we can reduce the variation in the handover process by using process mapping. We must keep the focus on patient care with clear roles and backup behavior, clear transfer of information and professional responsibility, and finally the need to ensure closed-loop communication. The process maps are an important tool because they enable visualization and logical synchronization of the transfers. In this study, Vinny Arora and her colleagues looked at communication failures during handoff on an internal medicine ward. As you can see, medication errors, tests, and active medical problems were the key issues in poor sign-outs. What's very interesting in this and follow-up studies is that when the trainees were asked if they thought the handovers went well, 60% of them said it went very well, even though only 40% actually went well. So the most important piece of information was not communicated. They did not agree on the rationale provided. Some things were likely not to be remembered. And finally, the peer assessment was quite high in spite of the problems just alluded to. Question is, in the next slide, is the problem with listening? That is to say, is it displaying of understanding? Is it processing information? Or perhaps it's interruptions and distractions? And these are very different issues which are worth drilling in to better understand. We know, for example, that when people communicate one to each other, they might nod, they might make eye contact, they might even parallel their body language. But that's not enough. We need to actually have readbacks and note-taking and perhaps actually interrupting the sender in order to make sure that the information is understood. So, is the problem in the sign-outs? In the next slide, from another study from Vinny Arora, what we showed was that over half the handover failures had the potential to cause significant harm to patients. Here's another study from 2005, the Anticipate study, again, looking at routine cases of emergency patients and focusing on new information, what is essential, the administrative data, the new clinical update, the task, the illness, and finally, the contingency planning. What if, what should we do in case A or case B, for example, if a code status, or for example, if the patient has a sudden new change in heart rate. In the next slide, I want to highlight Atul Gawande's book, The Checklist Manifesto, which of course has become the holy grail. But as you can see in the next slide, there needs to be a caution around using checklists. A checkbox mentality might be a problem if people don't actually know what's inside the checkbox. Number two, the forms actually need people to fill them out, and that means buy-in from providers. Clearly, one size does not fit all, and therefore we need to customize these checklists. And finally, unless the providers are engaged in designing the checklist, it's likely that their behavior change will not happen, and therefore auditing and engaging frontline staff is key. Next slide speaks to the SBAR, a tool that many of you are familiar with. The acronym of SBAR is a technique designed to communicate critical information succinctly and briefly. The acronym stands for Situation, Background, Assessment, and Recommendation for Action. We also know in the next slide that there's a misuse of SBAR. For example, I'm SBARing as a verb as opposed to understanding what the elements. Number two, failing to customize and specifies the precise elements in each category. And finally, the assumption that using SBAR checklists will result in understanding, even though we know that it requires information transfer and face-to-face or verbal-to-verbal communication. In the next slide, Joe Sherritt and his colleagues published studies looking at transitions of nursing care in the ICU, and what became very different are the different perspectives between the incoming nurse and the outgoing nurse. This study used interviews and ethnographic observations. What the study clearly showed was that omissions in communication, ambiguities in communication were clearly central to the misunderstanding. For example, the outgoing nurse would say, "I had some troubles with this port." The incoming nurse would say, "After hooking everything up, it didn't work, and I could not get medications in. I should have asked more questions." Clearly, the lack of asking questions by the incoming nurse led to that ambiguous information. Next slide shows a clear influence diagram around the impact of the end of shift, distractions, the level of experience, and the gap in communication, how they all come together to lead to false assumptions, leading to ambiguity in communication. In the next slide, we talk about care versus cure. This is a study that was done by the VA under the leadership of Rich Frankel. And of course, the attitudes of nurses and physicians is clearly different and important. Next slide shows quotes from resident interviews. Here's the quote. "Yes, it's like the only way I can make it manageable for my handovers is to tell the incoming resident which patient is going to need what during the next 8 to 12 hours. Next quote, "I just try to give him or her the most pertinent information about what has happened during the last shift and to watch for the next shift." Clearly, this is very different than the following quotes. These are from nurses. "I try to go through each patient with the incoming nurse so that they can get a complete picture of what's going on. It's important for me during shift change to provide as much information as possible to the person taking over. I believe in taking the time to fully inform the person replacing me about the status of each patient's care." The preliminary findings from this study from this and the next slide show that physician handoffs tend to be done by exclusion, whereas nursing handoffs tend to be much more detailed, information-rich, and much more detailed on each element of the patient care. It's possible that these styles represent very different mental models held by nurses and physicians respectively about patients and what is required to manage and maintain their care over time. This next slide shows a fishbone diagram or an Ishikawa chart in which we looked at barriers to communication that might be related to policies, patients, professional work, the place of the care, or the procedure at hand. The next slide is another study that we did in the Handover study, led by Julie Johnson, Vinny Arora, and myself, in which we looked at artifacts analysis. In this graphic, we can see superimposed on the process map are pictures from the patient's medical record, pictures from the medication CPOE system, pictures from the discharge information, and altogether a very complex narrative of what happens during the transition of patients. The take-home message from this slide is that this is much richer than just what's in the chart. This really has to do with a wide variety of tools that are used to deliver complex care to patients. What about training, monitoring, and evaluation? Again, we talk about interviews from the study that Joe Sherritt did, published in 2008, which we looked at what the nurse managers were saying. Here's one nurse manager after 15 years on the job. Nurses are so individualized and patients are so individualized. It'd be very difficult to standardize the process. Here's another nurse manager. You buddy up with a senior nurse for a finite period, and you learn from that nurse what should be communicated in the next shift. This is very time-dependent, very context-dependent, and clearly dependent on supervision and mentorship by senior providers. Patient simulators in the next slide are a huge part of training around transitions of care. You'll see some examples here from Harridan's work, examples from Varkey's work, from Stoneworks, and from Barach and Mayer's work, in which using OSCEs and OSHEs in order to communicate better clinical skills. We know, for example, from Farnan's work in JGIM in 2009 that an objective simulated handoff experience, so-called an OSHE, can help to dramatically improve the skill sets and transitions of care. For example, a 10-minute to review a mock patient, and of course, following the reason for admission, the home medications, and the contact information were helpful. Another thing that Vinny Aurora has done is a CEX. These are clinical examination scenarios, 5 minutes, in which a provider is assessed on core elements such as follow-up information, requirement for equipment, and the family meeting. Handoff CEXs can be used to assess incoming and outgoing trainees, and based on a 9-point scale can be adapted to nursing as well as to hospital-based providers. Another example of this in the next slide is peer evaluations, asking providers to assess each other as far as their competency based on are they listening, do they actually manage the transition well, and was the care of superior outcome. Gibson et al. Has shown in the next slide that communication is really a two-way street, best understood as a dialogue versus a monologue, as an interaction that fosters a common ground, empathy, and equity to transfer the necessary information. The sender then must paint a picture for the receiver so that they can understand what was being said. What can senders do? They can think about the 4 R's, the relevant items that must be remembered, directions with rationale, and checking if the receiver understood. That is to say, encouraging readback and overcoming the typical egocentric heuristic about thinking about the receiver and not just about the sender. What can receivers do? They can actively listen, they can ask better questions, they can use a systematic way to follow up on patient information, and they can read back the information to ensure they're on the same page. The next slide shows the handover toolbox. This is a toolbox that we created in the project, and you see it in the references. There's examples for training, there's examples for common practices, and there's examples for better understanding handovers in the perioperative, peri-hospital, and peri-community process. The next slide shows the Donabedian causal chain, looking at the relationship between process and outcome and how where you intervene in the process can impact how much impact your interventions will have. I want to summarize this podcast with a few slides. Number 1, Handovers research biggest challenges are around evaluating health policy and human factors in situ, developing robust tools for management of transitions of care, engaging and empowering patients, engaging physicians and allied health around these issues, developing and testing practical and innovative models, including health coaching, medical helms, and finally, ongoing assessment. The next slide shows what are the elements of effective handoffs, effective communication, anticipatory management, continuity of care, and finally, interprofessional and collaborative teamwork. This slide from the University Health System Consortium is about risk stratification of patients that require transitions. Number 1, is the patient physically moving? Is the patient critical or unstable? Is the patient temporary or permanent? And is this the first time the receiver is hearing about the patient? Clearly, if there's a yes to any of these questions, there's much more risk in managing the patient. I want to say a few words about TeamSTEPPS Framework. This is a framework that we developed many years ago that looks at knowledge, attitudes, and performance as it particularly relates to transitions of care. And as you can see in the next slide, handover skills are clearly and should be part of the training of the clinical microsystem. They're essential links, they're team-based, and holding clinical members of the microsystem accountable is part of what the team should look like. What is generalizable? Clearly a process and content-driven improvement strategy, and the collaborative format of team-based learning is clearly at the heart of this. As we go forward, we need to address several challenges, including organizational, cultural, professional barriers, the sustainability of our interventions, creating local leadership, and finally, can we prove that our interventions actually make a difference? So that is to say, do they add more value to the providers? Do they add more value to the patients? Do they add more value to the system? What are some of the lessons learned? Handovers are an integral part of daily clinical work. That is to say, improvement must be driven by those at the coalface. There's the research, but then there's the improvement, and we need to better understand how to integrate the research into the improvement. And finally, there are cultural differences between clinical units, between clinical disciplines, between different departments, and between different hospitals. We need to be able to customize and localize the solutions. Finally, the local leadership, all change is local, and therefore we need local championship supported by local management to make sure that the work gets nurtured locally and is supported. I want to end with 2 slides about training and engagement. Obviously, if we're going to have effective training, we have to make sure that the training is transferred well. And as you can see here from work published by Intern et al., that pre-training knowledge, skills, and attitudes are highly influential in priming the provider into listening to the intervention and changing their behavior, so that the priming helps the intervention work more effectively, allows a higher level of transfer of training, higher level of improvement. These individual factors are influenced by the safety culture, pre-training experiences, by the self-efficacy of the learner, and by the motivation of the learner. All this comes together to influence patient outcomes. I'm going to end by one last slide, which is a slide on the cover of a special issue of the BMJ, which is in your references. This special issue has 20 articles from the Handover project that will help tie together the elements that were discussed in this podcast. Thank you for your interest and attention. Bye now.